All righty. Good morning, good morning. I only see a couple of you have coffee in front of you. That is a very poor choice. Everyone needs to have coffee. That's part of the...
You didn't bring coffee?
No, here's mine. This is as far as I go. So, I am Rob Nolan. Most of you guys, in fact, I know almost all of you in here. But if you had forgotten me, which is probably usually a wise thing to do, I am the medical director for both ACLS and PALS, and the director of the emergency departments, and I wear a couple other hats around here, chief of staff and a few other things like that. So, how many of you guys, this is the first time you've taken PALS? Oh, we got about half of you taking PALS. And then the other half are what we like to call the experienced, or some of the gray-haired folk, which is I've gotten here. Just similar, how many, you guys all have ACLS as well? Okay, so very similar to ACLS and PALS, the huge value of this course is the stories and the experiences that you share with each other, okay? And especially with PALS. Fortunately, taking care of critically ill kids is a relatively uncommon situation. We see about 30% of our patient population in the emergency departments are kids. And of those kids that we see, about 90% of them are completely fine. They don't need our care in any way, shape, or form. In fact, we probably cause more harm than we do good by giving unnecessary antibiotics, by taking unnecessary x-rays, by doing unnecessary CAT scans, and all sorts of other stuff. Most of these kids just require a kiss on the forehead, some grandma's soup, and a good cartoon to watch, and they'll be fine in 24 hours, especially now that we have vaccinations. So any of you guys practice and take care of kids prior to, let's say, 1995 or so? I mean, don't out yourself. And the reason I bring that up is right around the 90s is where two huge changes in pediatric care took place. One is the Prevnar vaccine, right, which covers you for pneumococcus, and the other one is the Haemophilus influenza. Okay? Those two vaccines alone dramatically changed the outlook of care for kids. All right? It took care of the vast majority of meningitis cases and the vast majority of very significant pneumonia cases and things like that. So we can still get pneumonias, we can still get meningitises, we can still get epiglottitis, which is what Haemophilus caused. But I'll tell you, the last 4 or 5 cases of epiglottitis I saw were in 20-year-olds. Okay, I started practicing emergency medicine right about that time the Haemophilus influenza vaccine was coming on, and almost overnight, all of those cases of epiglottitis and things just disappeared. You don't see them in little kids anymore. So we've been very fortunate in a vaccinated society to have a lot of the classic childhood diseases and illnesses that we used to talk about and worry about a lot disappear. That is slightly changing now. And I don't mean to offend anybody, but with the granola movement going on and all these families saying, I don't want to vaccinate my kids, I don't want to vaccinate my kids, they're depending on herd immunity, meaning that if the disease prevalence in the society is low, and there's not a lot of Haemophilus floating around, or there's not a lot of measles, there's not a lot of those other ones, their kids are safe. But as soon as you get a critical mass of kids that aren't vaccinated, we're going to start to see these things pop up. What happened in Disneyland a couple years ago when they had a huge measles outbreak. So be cautious, because there's a lot more families out there that are electing not to vaccinate their kids for all sorts of reasons. And I don't want to get super political on it, but my personal opinion is they have falsely accused vaccines of causing autism. There are no studies that I know of, no credible studies that I know of, that say that that is indeed true. It is true that we are seeing higher levels of autism, but there's all sorts of reasons that can contribute to it. So just know it's a very touchy subject with families. People get very, very emotionally charged about it. I've got a couple of my attendings that just go off the end when they deal with families that elect not to. I'm a libertarian at heart, so I think you kind of get your own choices, but just understand that there are ramifications of doing that sort of stuff. So we might see some of these disease processes going up. Okay, so again, as you go through these stations and you start practicing things, share stories, share experiences that you've had, things that went well, things that didn't go well. More often than not, when you're taking care of kids, you're actually taking care of parents or grandparents and not necessarily the kids. The kids are pretty indestructible. It's the parents that are freaking out. I know, and this is a confession of an ER doc, which is probably not a good thing to do when I'm being taped, but if you look at my prescription habits at 2 o'clock in the afternoon during RSV season and my prescription habits at 2 o'clock in the morning, you'll find I prescribe much more antibiotics at 2 o'clock in the morning. Why? Because I'm tired, the parents are tired, they're freaking out, they're like, oh my God, little Susie, little Johnny's going to die unless they get their amoxicillin, and there's a certain point where you just say, I don't want to fight this. And you say, great, here's your small little dose of amoxicillin, even though I know dang well this is viral, and it will only cause problems. Sometimes that's the reality, because you've got to deal with family members as well. Okay, so we're going to talk about two things today. First thing we're going to talk about is respiratory stuff with kids, which is about 90% of all the things that you're going to have to deal with. And then we're going to talk about a little bit of toxidrome toxicology and things like that. The toxicology talk is not meant to make you a toxicologist. It is not to make you an expert in any way, shape, or form. It is to give you a heads up, because more often than not, you are the eyes and ears of these kids, and to recognize not everything that comes in is some sort of viral-induced something or other. Kids are stupid. They get into things, just like adults are stupid, and they get into things too. And we'll talk about that. So respiratory stuff that we're going to start with. We are fortunately not fully into RSV season, but we will be shortly, and that's always a lot of fun. We are getting now this little peak. This happens every single year. Those of you guys have been practicing for a while. School comes back together, and all these little micro petri dishes come together in one room, and they all snot and cough and rub their noses on each other. And about 2 to 3 weeks later, what do we see? We see a huge spike in all these kids that come in with upper respiratory stuff, right? Runny noses, coughs, this, that, the other thing. And so we're kind of running our way through that. And then about 2 to 3 weeks after that, who comes in? Their parents do. And I always kind of laugh, because the kids come in, and yeah, okay, they're miserable, they're coughing, and they might be a little hypoxic and wheezy and, you know, whatever is going on with them. But for the most part, they're pretty tough. Parents come in with the exact same thing, you know, the metapneumoviruses and the adenoviruses and the da-da-da-da-da, and they are just whiny. Oh my God, I'm going to get this cold. And you're like, oh, really? I mean, it's been the herd here a little bit. So that's what we're dealing with. 3 areas for us to look at for respiratory stuff with kids. And why do we focus so much on respiratory? You know, when you guys took ACLS, what do we talk about? We talk about heart, 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 heart. Well, with the exception of congenital kids, which we're not going to really bring in here, right? Kids that have tetralogy of flow or transposition of great vessels or had, you know, Eisenmenger complex, all sorts of weird things. The vast majority of kids that you see, if they're going to get in trouble, they're going to get in trouble with respiratory stuff first. And by the time it gets to the cardiac area, it's because they've decompensated from the respiratory. So it's hypoxia, 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 followed by shock, and then followed by hypoxia. And then eventually they go off. The other little adage that I want to kind of dispel that people talk about all the time is somehow kids are magically going along perfectly well and they fall off cliffs and adults like slowly fall down. And I would say, no, what really is going on is we're just not recognizing the kids going down. And it's really that they're not just falling off a cliff. It's this we didn't catch what we classically look for, right? Kids respond by getting tachypnic and tachycardic. They usually don't alter their blood pressure as much. They don't have the same sort of autoregulatory control that most adults do. So adults, you know, we're constantly looking at their blood pressure slowly going down, and we're like, oh, you're getting more tachycardic and more hypotensive, and we get a little more concerned. Kids have a tendency to maintain their blood pressure pretty well, and only at the very end, when they basically have exhausted all their resources, do we see their blood pressure drop. But if you watch these kids, they actually are telling you when they're in trouble. They're getting more and more and more tachypnic. They're using more accessory muscles as they're working harder and harder and harder. They go from sitting up and smiling to not responding, kind of tripoding a little bit and working harder and harder. You'll see their tachycardia start to go up. You know, you get a little 2-year-old that comes in. If they're in the 120s, you don't worry about it. If they're in the 150s, 160s continually, you start going, that's a little scary. And then they start becoming hypoxic. Now adults who have abused themselves forever, you think about a typical COPDer that you see, and they come in statting at 91, 90%, you're like, yeah, okay, that's because you burned out your lungs on cigarettes. Fortunately, most of our kids have not burned out their lungs unless they're like cystic fibrosis kids or something else like that. So when kids start getting significantly hypoxic, that's kind of a concern, because most of those kids at baseline have good functioning lungs. So something's going on when these kids are starting to get hypoxic, and that's when you really should start paying attention, okay? So that's the respiratory stuff, and that's why we're going to spend so much time focusing on those. I like to look at the respiratory in 3 separate components, and when you come on to a kid that is there, and by kids we're talking 2 totally different spectrums, right? We're talking about young little kids, newborns, you know, 3-6 months, but they also lump in 16-year-olds, right? And there's tons of 16-year-olds that are bigger than I am, that are basically little adults. So, you know, and we're going to do the same thing with Toxidromes later on when we talk about it. There's a difference between a little kid cruising on the floor, picking up a pill and throwing it in their mouth, and a depressed 16-year-old that's taking a bunch of things and intentionally trying to kill themselves. I've yet to meet an 18-month-old who's suicidal. Just does not happen. 16-year-olds are. Okay. But for the respiratory stuff, I like to break it up into 3 groups. We're going to talk basically supraglottic, everything up high. We're going to talk about the tracheal and kind of the bronchial areas, and then we're going to talk about the peripheral and the lungs. And so when you come across a kid, think about if they're having problems breathing or respirations, where could these problems be? Because our interventions are going to be slightly different in the things that we're going to work up. So when we start with kind of supraglottic stuff and things up above, we think, what causes swelling up here? Okay, well, you can get your bacterial infections, right? You can get your epiglottitis, you can get your retropharyngeal abscesses, you can get your really bad tonsillitis. Most of that is an airspace type issue, right? So if it's a bacterial infection, more often than not, we will see things like fever. The kids will look like hell, right? If you've got that much of a bacterial infection, these are the kids that are kind of sitting forward. Now, the big warning signs you have is, can they handle their secretions? If you see a kid sitting there having a hard time breathing and they're drooling and can't swallow, that is an emergency. That's an impending airway that's going to collapse on you, and you have to be really cautious with those. If you see that, you want to immediately get a hold of somebody who can grab an emergent airway fairly quickly, okay? Back in the days when we had epiglottitis and things like that, those were the big concerns. It used to be taught that you don't mess with that kid, you don't start IVs or anything until you have all your emergent airway stuff there. Again, that's a very rare thing for us to see now, but that's the worst end of the spectrum. What do we typically see? Well, we typically see kids with sore throats, tonsillitis, things like that. They might have a little stridorous sound, so most of these kids, when you listen to them, it'll be kind of a tighter sound up here. If you think it's virally induced or something else like that, usually things like steroids that'll reduce inflammation, and sometimes like racemic epis and things like that they can breathe will help them with those. Okay. The other thing that you have to think about is there an airway obstruction, right? A 15-year-old should be able to tell you, oh, I was running with a pen cap in my mouth, and all of a sudden the pen cap disappeared, and I'm having a heck of a time breathing, okay? Little kids don't tell you that. So if you have a kid that was doing really well, and this is where the history is important, they have no prodrome, kid's been running around, playing outside, and all of a sudden, boom, they have this upper airway sound, you hear this stridorous sound, they're having a hard time breathing, it looks like they're really working to pull in air, you've got to think about foreign bodies, okay? First thing you do, take a look. Sometimes you have to get the x-rays to take a look and see what's going on there, depending on how deep it is. You know, if need be, you can sedate these kids. Ketamine's a wonderful sedative, and you can actually take a look with a laryngoscope. Now, it's probably not something that you're going to be doing, but in the back of your head, any kid that's been completely normal and then just something happened to them, think of a foreign body aspiration. Okay, so that's kind of your upper airway stuff that's going to go on in there. Viral, bacterial, and then, again, some sort of aspiration type stuff. Fortunately, not something that we see a lot of. Now, you could see it with some traumas, facial traumas and things like that. We have kids that love to run with stuff stuck in their mouth, right? They run around like that, fall down on it. You can get hematomas from those. But again, this is all kind of space-occupying things that you have to worry about. Okay, now we're going to go below the epiglottis and go into kind of the tracheal area and then down into the bronchus. These are very common things that we see, right? And this is going to be the vast majority of what you're looking at. These are some sort of inflammation that occurs. You can get your tracheitis, you can get your laryngitis, you can get your bronchitis, and you get your reactive airway components, right? So let's talk about first some of your infections. We talked about RSV earlier on, respiratory syncytial virus. Very, very common that you're going to see in younger kids, okay? We fortunately, I don't want to say are getting less concerned. We're getting much more liberal on how to treat these kids. What works for RSV? You guys that work in the ER or work up on the peds floor. Yeah, sometimes. How about steroids? Do steroids work? Not for RSV. Okay. How about breathing treatments? Nope. Really nothing other than maybe supplemental humidified oxygen helps for these kids. And it's a real pisser, right? Because these kids, a lot of times, have this snotty nose. They kind of look like crap. They're breathing fairly quickly. You pull off their shirt. I would recommend making sure any baby that you see needs to be a naked baby, okay? Adults, sometimes it's scary to look at, so you don't need to make them naked all the time. But babies, you want to get them naked, right? Because you want to look at their chest. You want to see what's going on with their chest wall when they're breathing. Are you seeing rib retractions? Are you seeing supra and infraclavicular retractions when they're taking a breath in? And if you stop for a second and think about it, where's the energy component in breathing? It's the taking the breath in, right? Exhaling's a passive process. Inhaling's an active process. So if they have to work to pull air in, to make that suction, they're going to suction in everywhere, and if there's some sort of obstruction along the way there, so whether it's bronchial constriction, whether it's some tracheal constriction, anything else, you will see that negative interthoracic pressure in the chest wall. You will see the rib retraction. You will see the supra and infraclavicular retractions. You will see them belly breathe, right? Those are the things that we're looking at to say, is this kid working hard to breathe? And they'll become tachypnic. They're going to increase their minute ventilation or attempt to increase that stuff, right? RSV is just a viral inflammation that unfortunately nothing helps. And it is a big pain because parents want something. They want an antibiotic, they want a magic pill, they want that unicorn fairy dust to go over their kids so they can sleep at night, right? And that's when we see it most often. Mom and dad are trying to sleep, kids in there just coughing, looks kind of cruddy, and they go, oh my God, I've got to come and get the magic pill to make them all better, and there isn't anything. Now, we used to get really concerned with these kids becoming hypoxic, and we still do, and we get concerned with these kids if they're working too hard to breathe. But over the years, there's been some great studies that have come out, and one of which, I have no idea how they passed it by the RRB, showed that really we can let these kids get pretty hypoxic. We're talking down into the 90s. And here's how they did the study. They went into a bunch of emergency departments, and they automatically changed what it said on the pulse ox. So the doc walks in, and they see this kid, and it's kind of working, and the kid's pulse ox was actually like 89. And they lied, and they changed it on the machine, so the doc thought it was 95. The doc said, kid looks okay, and his pulse ox is 95, we'll go ahead and let him go home. And so they followed up these kids. And lo and behold, it turned out that these kids that were hypoxic did just as well as those kids that weren't hypoxic. And, I'm sure when the docs found out that they were getting lied to, they're like, you did what to me? But they passed the whole thing. So we can actually let these kids get fairly hypoxic. What we're really looking for is, are they getting dehydrated? Okay, are they working so hard that they're not feeding? Or are they working so hard that they are starting to tire out? So a lot of these RSV kids that we see now that come in with 90s and 91% SATs that are, 5, 6, 7 months old, those kids can be followed up at home if they have a good home environment. Okay, that's going to be the big key on this one. If you have a trustworthy parent that has transportation that can come back if the kids get sicker, we can send those kids home. If not, how many of you guys are working on the peds floor? Awesome. We have our wonderful pediatric colleagues here that I'm sure are just more than happy to watch these kids overnight. And you guys just do that. Just watch them. Make sure they're eating and drinking. They don't get significantly hypoxic, and then hopefully the next day they can go home. So that's probably one of the most important things to look at with some of these kids that are tweeners, whether they can go home or not, is what kind of psychosocial issues do they have at home, right? If they have a 16-year-old mom who can barely function on her own and she's the only support, that's probably not somebody that you want a kid to go home in that environment. They're having a hard enough time just at baseline, let alone having the stresses of having a sick kid. If you've got a mother of 5 who has, a partner at home that has transportation, she's been to this rodeo 400 times before, that's probably somebody that can handle this quite nicely. And she was probably in there just because she needed a break from the other 4 kids and just said, an ER is a less chaotic spot than home. Okay, so that's kind of your RSV stuff. What else do we have in that mid-airway stuff? We have croup, right? Parainfluenza virus. And what do the croupy kids sound? Anyway, you guys, I know my peds colleagues. Bark, exactly. And I love it because I get my interns in, and most of them have never heard of croup before. And as you're walking towards a room with the curtain drawn, you hear, and you're like, I'm done. I don't even need to see this kid, right? That is croup as far as it is. The other thing about croup that parents find super frustrating is they sound like this barky seal at home, and it's usually wintertime, and they get them up, and they bundle them up in the car, and they drive over, right, and they get that blast of kind of cool, moist air out there, and they come into the emergency department, and the kid sounds fine. And they're like, I swear to God, I have it on my phone, is what it sounds like. And you're like, okay, wonderful, I believe you. But that's a very classic type of thing with croup. It breaks with some moist air. A lot of times just changing either warm or cool environment will break that kind of croupy cough. You used to take x-rays. I don't recommend it anymore. They call it the steeple sign. You get a little bit of narrow stuff. It's just that high barking cough, okay? Now, unlike RSV, where really nothing but kind of humidified oxygen works for this, these kids respond quite nicely to steroids. Okay, Decadron is very classically what we used to give, either 0.3 or 0.6 mg per kg, doesn't really matter. The thing to tell parents on this one is that croupy cough is going to last for a while. So they're not going to just magically be fixed. Steroids take about 4 to 6 hours to kick in. They will be just fine. It is contagious, so if they've got other friends, they'll be okay. Again, what do we look for these kids? Are they feeding? Are they dehydrated? Is their work of breathing so difficult that we need to watch them? Sometimes if they are really at the extreme ends of this, where they're having a hard time stridorous breathing, we will give them racemic epi to help them breathe, okay? Relatively uncommon, it does help a little bit. They'll get tachycardic, they'll get jittery and things like that. But vast majority, 99% of these kids, don't need anything more than Decadron. Again, psychosocial stuff at home, you might want to bring them in to watch them just if mom is having a hard time at home dealing with this stuff. You've got that kind of gestalt feeling that maybe it's a little bit better to have some professionals just watch them and make sure that they're getting fed. Sometimes we admit kids, plug your ears guys, just for timeouts for parents. They've just hit that break point and they just need some help, and having a sick kid at home is just too much for them. So yeah, come on up. You know me. I'm not going to spit on you. But that's the group, okay? So those get steroids. The last kind of group in general that we have here is going to be your reactive airway diseases. All right? This is a very hot, debatable, minefield-struck area. Okay? Why do I say this? Because I love my pediatric or my pediatrician colleagues, and we always have this huge debate every year, and it will come again this year. Okay, I told you with RSV, which is very common, bronchodilators do not work. And they don't work, right? And you listen to these kids with bronchiolitis, RSV, and what do you hear in their lungs? Well, you hear this kind of crappy, kind of maybe sort of wheezy stuff, maybe some, it's just kind of, they're all breathing through their nose, so it's always just like sort of crap stuff there. Okay, what does reactive airway disease sound like? That sounds kind of wheezy, and they usually have virally induced stuff, and they're crappy in their nose, and da-da-da-da. So you get this kid in front of you who's snotty and isn't super hypoxic, and it's kind of, and you're like, wow, is this bronchiolitis? Well, I don't have my RSV panel back yet, or I might not even want to get an RSV panel because it's $400, and that's an awful lot for just a viral thing I'm not going to do anything for. Does this kid have a reactive component? Because there's a lot of, the metapneumoviruses and the adenoviruses and all those other stuff can cause a reactive airway. Notice I'm not saying asthma, because really you can't have asthma until you're older than a year or so. But you can have a reactive component to it. So a lot of times what we do in the emergency department is we give them an albuterol nebulizer, right? And some of them get better, some of them don't. So this is kind of how we diagnose RSV versus all the other little reactive airway stuff. If you got better on a nebulizer and your breathing got easier and your lungs sounded better, well, guess what? You had a reactive airway component. We're a hero. Woohoo! If we gave you the albuterol and all you did was get a little more tachycardic and jittery and it didn't change any of your respiratory stuff, guess what? You probably have RSV. And then hopefully we stop. Now, sometimes it's shames on us. We give a second one, and you're like, okay, if it didn't work the first time, idiot, it's probably not going to work the second time. So, that's on us. But a lot of times we use the bronchodilators, the albuterols, as kind of our test diagnosis of, do you get better on this? If you do, we know you have a reactive component, and it's probably not completely RSV. If you don't get better, it's probably RSV. We can always send the culture out, but my ER folks, how long does that take? It's always like the last thing to come out, like an hour and a half, 2 hours later, and now you've got a snot-nosed little kid who's really not that sick, and you keep him in an ER for 2.5 hours to pick up God only knows what other bad mojos floating around our ER, to then say, I now have diagnosed something for $400 that I'm not going to do anything different for. Okay, so, we have to be a little bit careful. So a lot of times that'll be that's what we use it for. So all the other reactive airway stuff, and then when they get older, older than a year, year and a half, and they actually start developing asthma or asthma-like bronchoconstriction, albuterol in those kids when they're wheezy, and then steroids as well. Okay, so have we given steroids to kids with RSV? Absolutely, because we thought there was a reactive component. It's not going to kill them, but it's not going to help them. What we're trying to do is figure out which group of these kids have bronchoconstriction and have some sort of reactive airway component, which I'm going to throw asthma in a little bit later on, versus those kids that don't. And it's sometimes really hard to tell. So what's the one big modality that I did not put into this whole workup of this, kind of bronchitis type group? A chest x-ray, right? We are really trying to reduce chest x-rays in these kids because rarely do we find pneumonias. Okay, pneumonias are peripheral diseases. We haven't gotten to the periphery yet, right? So pneumonias, you should have focal findings. You should have fevers. You should have some fairly significant hypoxia, and most of these kids look relatively sick. Okay, the vast majority of the kids that we see, they look like little punky kids with colds, right? They have snot-nosed little, and I have kids. I love them. But they're not toxic looking. They're running around. They might be mildly hypoxic, 93, 94, or whatever. Yeah, they're breathing a little fast, but they're not horribly sick or anything else. Almost all of those are invariably viral. Okay, and we don't need to do chest x-rays on them. We participate in a Blue Cross Blue Shield consortium called MEDIC that we've been running for about a year and a half. And Blue Cross Blue Shield would love to let us all know that they're concerned about quality of care and exposing kids to radiation and all that other stuff, which there might be some truism there. But really, I mean, what they're looking at is if I can take less chest x-rays, I have to pay less money, and as an insurance company, that's wonderful. Now, if we spare the kids some radiation, that's even better too. But I will let you know that as of last month, the Lakeland Health System was #1 in the state of Michigan for preventing unnecessary chest x-rays in kids with upper respiratory infections. Yeah, so we did really, really well. We run about 4.5% of kids that ultimately get diagnosed with an upper respiratory infection. So we're talking RSV, croup, asthma type stuff, only 4%. The state average, 42%. We beat the children's hospitals, which is really pretty good on that one. Now, I think the children's hospitals might be, that one's a little tougher because they have a lot of the syndromic kids. You know, my threshold for getting a chest x-ray on a kid with horrible CP that has aspiration problems and everything else, I will probably get a lot more chest x-rays on those kids. You know, kids that have all sorts of genetic abnormalities that you're like, I had to look up what this crazy syndrome was. I usually will get more chest x-rays. So they have, you know, and they have cancer kids and all sorts of other stuff that makes it a little more challenging. But really, we're doing very, very well. So what do we look for and what do we teach our residents? And this is going to be our migration into the outer airways of when to get a chest x-ray. Okay, well, I talk about the 5 F's. And they love to hear about this. The 5 F's are, you know, if you are kind of wheezing and you're having this bad stuff, so do you have a fever? Okay. Is this the first time? So if you come in and you're wheezing and you've had it all your life, well, then I'm not going to get a chest x-ray. It's the very first time, I will consider it. All right. Did you have a failure to my treatment? So you were kind of sick, you had this wheezing stuff, and I treated you, didn't get any better. Okay, I might consider getting that one. If you were, pardon this one, effing hypoxic, all right, so there's another F right there. So you come in and your SATs are 82%, you're probably going to get a chest x-ray from me, okay? And do you have focal findings? That is the last F. So I listen on this lung and I hear crackles and garbagey stuff here, and I listen on this one and it's nice and clear. Okay, that tells me that's a peripheral type thing. That's out in the lung parenchyma and not in the bronchioles or not up in you know, the trachea and all that stuff, okay? So I listen to a kid and I see that it's a unilateral finding, not a bilateral finding, right? If you have wheezing and viral stuff, it hits the entire respiratory tract, so you should hear it on both sides pretty much evenly. So if it's focal findings, if it's a significant fever, if they are effing hypoxic, if they failed to my treatment, and it's the first time for them, then I'll consider getting chest x-rays on those. If it doesn't hit one of those, then I tell my residents, you don't need to get a chest x-ray. Because the vast majority of the time you're not finding anything. And even if you do, what's the #1 cause of pneumonia in kids? Viral, right? So, you know, again, with the metapneumovirus, or the pneumococcus vaccine, our incidences of true bacterial pneumonia have really dropped. It used to almost always be strep pneumo, strep pneumo, strep pneumo. Every now and then some children's hospital comes out with what they have their #1 causes, and now we have things like the mycoplasmas and all these other, you know, weird atypical things that are causing bacterial pneumonias in kids. Again, different age ranges on that one, okay? So, last little bit on that central stuff, asthma. We typically don't see asthma until you're about 2 years of age. And you guys have all taken care of asthmatic kids, right? Most of these kids have had an episode before. They have all sorts of things that induce it. Could be a viral infection, could be exercise, could be whatever. They could have an allergic reaction. I don't know what has happened to peanuts in the last 30 years, but now we get all these kids that are allergic to peanuts. I mean, they even look at Mr. Planters and they go into anaphylactic shock. It's just pretty awful. We see these kids come in, all the same sort of thing. Yeah, how many peanut, there we go. All right, so we always have, you know, one of those people in here. We can never invite you to Dairy Queen, thank you very much. These kids come in wheezing, you're going to hear your bilateral wheezing in there. Mostly it's the expiratory wheeze that you hear. And how do we treat those kids? We treat them all with albuterol. We'll sometimes add itroponium on top of it, depending on their age, and we keep bumping that one down lower and lower and lower. My threshold is usually about 4, but I know some pediatricians that will use it at 2. There's no huge problems in going ahead and giving it. We give them that, and we give them some steroids. If they're super, super, super sick, we'll add epinephrine on top of that as a bronchodilator, okay? So that's your asthma type kids, and most of those asthma kids can turn around. The group that is really, really dangerous are the asthma kids that you have to eventually intubate. Now, the kind of thing that I teach my resident is when you go to intubate an asthmatic kid, so this is a kid that is probably working so damn hard that they're super tired and they're just about ready to just stop breathing because they're exhausted. You get that ET tube there, and then you go, I'm going to wait a minute. It's the only time I ask them to wait to intubate somebody, because as soon as you take away the respiratory drive in an asthmatic, you are asking for problems. Because what happens in asthma? What swells up? The bronchioles do, right? So you are now drinking a McDonald's shake through a tiny little coffee straw. That's pretty much what happens to those bronchioles. And it's really hard. And again, we said that the energy requiring portion is inhaling and the passive portion is exhaling. Well, what do we do when we put somebody on an intubation? We give them positive pressure, so we blow them up, and then we hope their chest will recoil to come back down to exhale. Well, what's blocking these kids? They have these tiny little bronchioles, and so they'll start to air stack, meaning you push air in, you put them on high PEEP, and then they can't exhale. And you keep pumping their chest up until, God forbid, you pop a lung. And if you pop a lung in an asthmatic person, you are up a creek without a paddle. So a lot of times in these folks, what we end up doing is we actually take them off the ventilator and we'll have to physically push their chest down. I had a gentleman when I was up at University of Washington training that was a horrible, horrible asthmatic, intubated the guy, and my tech stood there for an hour that we would blow him up and he would physically have to push him down for an hour and physically push him down. That's the problem with asthmatics. You have to really be careful and watch them so they don't stack these breaths, because their issue is blowing out. And think about it, the next time you see an asthmatic, watch them breathe. They take a breath in, and that's not so hard. It's the and that's where you hear them. It's that expiratory wheeze stuff. So if you ever are taking care of a kiddo that you have to intubate on asthma, just be very careful. We don't do it very often. Hopefully the doc that's with you is savvy enough to know that they need to change how long these kids expire and everything else, the IDE ratios, but just watch for that breath stacking, because their pulmonary pressures will start to go up really high. Okay, so that's it for that portion. Now let's get out to the pneumonias and the peripheral stuff. Pretty straightforward, right? Either viral or bacterial cause these type of things. These kids usually look sick, right? You got a big chunk of real estate that has a bacterial infection in there. Again, pneumococcus used to be the most common. Now we're seeing a lot of the other atypicals show up and things along that line. These kids will almost always be febrile, focal findings, looking kind of toxic. They might be fairly tachycardic. These kids need antibiotics if it's bacterial, okay? The virals, you get that little perihilar fluffing if you ever get the x-rays, you know, kind of looks like this little dusty pattern in here. The bronchial pneumonias, if you see them, you get that loculated white patch in their lung, okay? What do we typically give for antibiotics? What works well? What do we give for every single kid that seems to have any significant illness? Okay, amoxicillin, but if we want to give something IV, Rocephin, right? Rocephin cures, I swear to God, literally everything. If the kid happens to have gonorrhea, you got it. Rocephin is your medication, right? If you ever were stuck on an island, the two antibiotics you want is Rocephin and Doxy, right? Because Doxy takes care of all those stupid, crazy little things like tick-borne illnesses, Rocky Mountain spotted fever, da-da-da-da-da. So if you have a sick kid in front of you and you don't know what it is and you're like, Rocephin is almost always your answer. Okay, little tiny babies, Rocephin. Now, after their 30 days, it's Clafrin before that. But you know, you don't have to worry about the toxic kids and the newborns. But Rocephin will take care of almost all this stuff, right? Takes care of your pneumococcus, you know, most of the other stuff. Now, your atypicals, you do have to do a little bit more coverage on it. But those shocky, lousy-looking kids, you have to do that. Now, what's the other thing that you have to worry about with these kids? It's fluid resuscitation. Most of these kids, because they've been breathing so rapidly, are just basically blowing off vapor. So they get dehydrated, and kids get dehydrated fairly quickly. So give them that bolus, and that's one of the things that you guys look at when you do your PALS resuscitation, is give them a fluid challenge. Give them 10, 15, 20 cc's. I usually start with a 20 cc bolus, see how they do, if they respond well, if they start making urine. If they look better, great. If not, I give another bolus of fluids to these kids. Okay. The other group that you will take care of that has nothing to do with respiratory are your DKA kids. Right? And a lot of these DKA kids have been coming in and they've been puking for 2 or 3 days. They've been pissing their brains out because their sugars are way high. They're just doing really poorly. How do we treat those? Okay. Old mantra was, oh my God, don't give them fluids because their brain's going to swell up and pop outside their head. A bunch of research has been shown that that is not indeed the case. You don't want to over-resuscitate these kids, but if they have been puking their guts out, they're shocky and everything else, treat their shock. Give them fluid boluses. I usually start at 10 cc's per kilo on those kids. And treat them until they start urinating, and treat them until their capillary beds start puffing up. And you guys have all seen kids that look really dehydrated, right? You press their fingernails, and it takes 5, 6, 7 seconds for it to come back. Those are kids that are under-resuscitated. They should be, like most kids, pink, fluffy-looking angels, not these like desiccated-looking little raisins. So give them the fluids to get them back up there. Okay, so that's the pneumonia, that's the respiratory stuff. Last thing for oxygen on that, most kids will do quite nicely with blow-by oxygen. Don't wrestle with them too much. One of the things that we don't have here is high flow oxygen, and I've got to talk to Zandra to see if we can get this for kids. Kids don't like things like CPAP. They don't like stuff blowing in their face, but you can actually use high flow humidified nasal cannula oxygen and deliver a tremendous amount of oxygen for these hypoxic kids, and it works beautifully well. I always found that it's best to let mom have the kids sit on their lap, and if they want to just hold a mask and just let it blow by, they will auto-titrate how much albuterol they're getting if you're giving them a breathing treatment. Do not worry about overdosing kids on albuterol. They will auto-titrate that sort of stuff. And continuous nebs, if they are truly having a reactive component, is fine. So just give neb after neb after neb as long as it's working. If it's not working, well then go back to the drawing board and find something else. Okay. Questions on upper respiratory stuff? We're coming in it. You guys are going to see tons and tons of it. Yes? Yep. First time, fever, failure for treatment, focal findings, effing hypoxic. Okay. I know the last one, I have to admit, is kind of chintzy. All right, any other questions on the respiratory stuff? All right, that truly, when you guys look at kids that are sick, outside of the focal, things like the cellulitis or appendicitis or all that other stuff, almost all of the stuff that you're going to see with kids is respiratory. And if you have a kid that's down, it's respiratory, and you've got to get the oxygen to them and then take care of all that other stuff. At the very end, then it's cardiac, and that's the last thing to go, because hearts are young and strong, and they can put up with an awful lot of insults. If you can fix that hypoxia and the respiratory stuff, you can get most of the other stuff down. And the other key component is fluid resuscitate, fluid resuscitate, fluid resuscitate, right? These kids get dehydrated fairly easily, especially if they're breathing really rapidly. They're blowing off a lot of that stuff. And you can see when you look in their mouth, they're going to be dry, they're going to be tacky, they're going to have that slow capillary refill. All right, toxidromes. We're going to talk about common toxidromes that kids get into. Now, again, like I mentioned earlier, kids, I divide into two separate groups, right? We've got the little ones that are innocent and just get themselves into trouble out of sheer stupidity being kids and doing that other stuff. And then the teenagers, which are just bound and determined to do even more stupid things, but they do so knowingly. So how many people in here have teenagers or have had teenagers at some point in time? A couple of you guys? Yeah. I mean, there's no more tomfoolery in the world than what teenagers can get themselves into. And we'll talk about them as well. Oops. Are you not? Oh, how about if I go this way? Okay. Couple pills that can kill. And every year there's, somebody gives a lecture somewhere around there, the one pill that can kill. When you have kids that come in that have gotten a hold of something, and this is typically your small kids, so we're talking 18 months and younger, maybe 2 if they're really that curious. Right? Kids are just vacuum cleaners. They go around, they discover the world by picking up stuff, dog crap goes in the mouth, dust bunnies goes in the mouth, funny little Legos goes in the mouth. Grandma's pills, they all go in the mouth. And so what we see a lot now is, especially when we have more and more blended families, so kids aren't living in the same environment or they're visiting different environments. So, grandma or grandpa's got a little bit of Parkinson's, and they have those wonderful little pill packages, and they open them up, and the pills go everywhere, and they all have macular degeneration, so they can't find where the damn pills are on the floor. And then in comes a little vacuum cleaner coming around, and there's a little red pill on the floor, and in the mouth it goes, okay? Very common, we all see these things. These are the pills that if a kid comes in and grandma or grandpa says, yeah, I think I lost one of these, and maybe little Johnny or Susie got a hold of them, you have to be concerned with, okay? Clonidine. I hate clonidine. I hate clonidine. I hate clonidine. It's a crappy blood pressure medication. It's fourth line regulation, but it is being used fairly frequently. It's being used for blood pressure control, but what are we seeing it a lot more for now? Opiate withdrawals and things like that, right? So clonidine, it's an alpha blocker. We're seeing a bunch of it out there. This is one pill that if a kid gets a hold of it can kill them. Alpha blockade causes massive hypotension, cardiovascular shock, okay? Anti-malarials, okay? We have Andrews around here, lots of missionary work, I don't know if any of you guys have been on medical missions and things along that line. We have lots of people that are going to and from malarial countries, and there's anti-malarials all over the place, and people, if they get back and they stop taking them, they're floating them around, but any of the quinines, the anti-malarial drugs, you've got to be real careful with those. Those can be fatal for kills. Suboxone. What's Suboxone? Yeah, it's for your heroin users, right? We see it all the time now. Substance abuse and everything else. With the heroin or with the narcotic epidemics running rampant, I swear to God, like half my patients that come in the emergency department now are on Suboxone. those can be potentially fatal. Calcium channel blockers and beta blockers, very, very common out of there, right? Almost anyone who has ever had a heart attack, congestive heart failure, things like that, they will be on a beta blocker or a calcium channel blocker for blood pressure control, right? Norvasc is a very common one. Metoprolol, atenolol, all those alls, those are all calcium channel blockers, beta blockers, and we'll talk about those individually. Not seeing it as much, but came from mothballs. I don't know why. You guys have all smelled mothballs before? I mean, does that inspire you to want to eat it? But kids do. I don't get it, but that can be potentially. All right, opioids, all over the place. And I can't, at least 4 to 5 times a year, we have a kid that's coming in like a little 8-month-old, 9-month-old that's acting goofy and super sleepy, and we can't wake him up, and all of a sudden we're like, the sugar's okay. Give him a little Narcan, and now the kid wakes up. Well, they got a hold of mom or dad or grandma, somebody's Percocet or something else like that, okay? So that's a pretty common one. Insecticides, not so much, but they certainly can happen. Organophosphates, again, some of the kids that are coming in from Berrien Springs, some of these farming areas, they have some of the organophosphates that are out there. Those kids are going to come in, they're all going to be frothy at their mouth and wheezy like all get up. Some of the toxic alcohols, right? Parents are out there. Now, we see this more commonly with pets, but ethylene glycol, which is what you use in radiator fluids and things like that, it is unfortunately, so I've been told, sweet tasting. And it's a very pretty color, right? Because they have that nice little green, so it fluoresces to see whether or not there's a leak in there. Grandpa's out in the garage, grandma's out in the garage working on cars. Little kid comes out and goes, ooh, looks like Kool-Aid. And truly, a teaspoon is enough to kill an adult. Okay, super, super toxic stuff causes renal failure. We can treat it quite nicely, but you've got to know that that's exactly what you're dealing with. Tricyclic antidepressants, they had disappeared in the 90s and the 2000s and are now back for chronic pain. Elavil is your classic one that you see with that. Okay, those can be fatal. I've had about 6 patients die on me from TCA overdoses. Afrin, believe it or not, can be fatal if kids drink that, enough of it. Caustics, which are going to be all your Dranos and everything else along that line, bleaches, and then sulfonylureas that we see in diabetics, right? So your glycerides, all those type of things. These are all, if you get a hold of them, you're in trouble. But now we're going to talk about specific ones. Tricyclic antidepressants. Elavil, being prescribed all the time now for diabetics with neuropathy and things along that line. So you're going to see it in a lot of your older family members and things. So the 2 people are going to get it, little kids cruising around, pick up the one pill that's on the ground, or your teenage, I don't like life, but I'm not smart enough to know that my gesture of trying to hurt myself is actually going to hurt myself. Kind of a little story on the tricyclic antidepressants. I worked down at Fort Hood in Texas, so military stuff during the middle of the war. It's kind of tough on a lot of families, and I guess a rumor was true. If you were critically ill and your spouse was deployed, they would bring your spouse home from being deployed. So people came up with all sorts of little schemes to get their loved ones out of Iraq and Afghanistan, which, we won't comment on that one. And I had one woman in particular who had some baseline mental illnesses, and she would, quote, overdose on different stuff in an attempt to try to get her husband back from Afghanistan. And she would overdose on Motrin, and she would overdose on, what else did she try to overdose on? A bunch of stupid little things that were basically, she tried to overdose on penicillin once. I mean, very benign things that you can't hurt yourself on. Well, her friend was a chronic pain patient, and she decided to overdose once on her Elavil, not knowing that tricyclic antidepressants can be completely fatal. So she comes in her regular weekly overdose thing, except this time she looks like crap. And we're like, oh my God, what the hell happened to her? Like, oh, and her friend was like, oh, she got a hold of my Elavil and overdosed. And within 30 minutes, she was dead. Okay, so with these, what are we looking for? Tricyclic antidepressants can do all sorts of stuff, but the big thing is looking at the EKG. Okay, it will block the sodium uptake channels, and so your QRS, which is normally supposed to be fairly narrow, now all of a sudden becomes really wide. So one of the things that we look at when we do an overdose workup and we get an EKG, the first thing that our eyes go to is that QRS complex. If that QRS complex is narrow, you're in fairly safe shape. Most of the time you'll see people that are tachycardic and things like that. If you see a wide QRS complex, you're in trouble, and this patient's going to crash pretty quickly. And the solution to this is bicarb, bicarb, bicarb. So what do you guys need to take home? If you see an overdose and you get an EKG and you see a wide QRS complex, do not wait. Get somebody immediately. Do bicarb for them. Okay. So there's how you give the bicarb, and then you just keep giving bicarb until her EKG narrows up. All right, so what happens to these people, or what do they look like? They come in comas, convulsions, cardiac, and then you always have to worry more in your teenagers, not so much with your little kids. Did they get a hold of other stupid stuff too? Because again, what happens more often than anything else, they get a whole handful of grandma's pills and they're like, F you all, I'm going to show you, and they just throw everything down their gullet. And you don't know exactly what all's in there. So be worried about other co-ingestants. The most common one on this one is you get a kid that comes in that is overdosed on an opiate of some kind, and you give them Narcan, you reverse it, and you're like high-fiving everybody going, this is wonderful, and then 3 days later their liver fails because they had Tylenol in with it, Percocets and Norcos, which is the exact reason why they've backed up on the Tylenol dosage on all of our Norcos, is because people were overdosing on these, and it wasn't the opiates that was killing them, it was the Tylenol toxicity later on that was killing them. Okay. Calcium channel blockers. Now, calcium channel blockers and beta blockers are essentially going to be the exact same thing. And you don't need to worry about the very subtle differences, because ultimately at the end of the day, we treat them about the same way. And even if you're wrong in which one it is, you're not going to hurt them with the other things that we add on to them, right? So calcium channel blockers, the really common one that you're going to see out there is Norvasc, right? Very commonly used for hypertension, is going to be used for tachycardias and things along that line. So if you think about what they're used for, what they cause in your patient is super easy to figure out, right? They block the AV node. So these kids are going to come in bradycardic. Now think about all the kids that you've seen in your entire career. If you piss a kid off, what happens to their heart rate? It goes up. If a kid gets sick and toxic and goes into shock and everything else, what happens to their heart rate? It goes up. Almost anything you do to a kid causes tachycardia. That's a normal response in a kid, right? Even if they're dying of hypoxia, even if they're, having whatever else, there are very few things that will make a kid go bradycardic, okay? Massive head injuries with brain swelling, some sort of toxidrome or something else, okay? So if you have a kid that comes in that looks sick and they're bradycardic, it is almost invariably going to be an overdose of something along this line, okay? So be scared of bradycardic sick kids. Tachycardic sick kids happens all the time. That's a natural physiological response, right? Their epinephrine, norepinephrine is getting surged up in their body. They respond by increasing their heart rate because, again, like we talked about, they don't really control their blood pressure as much as adults do. They control their heart rates. That's how they increase their cardiac output. So these kids are going to come in bradycardic, poor perfusion. You pinch their fingers. They stay white forever. You're like, this is a shocky-looking kid, but shocky kids should be tachycardic. This is a shocky kid that's bradycardic, so be concerned about those sort of things. All right, so what do we want to do? Well, that's what we do with everybody when we don't know what else to do. We give a fluid bolus, so give a fluid bolus, okay? Again, if these kids are bradycardic and they have a cardiac dysfunction, you do have to worry about a little pulmonary edema, but that's down the line. We give some calcium chloride, because if you have a calcium channel blocker, it's because there's not enough calcium diffusing into your cardiac cells. So we give a little bit of calcium to try to blunt that. If they're really, really, really tanking and dying on you, you can start them on an epi drip. Consider co-ingestants. Insulin glucose is probably our hallmark. We give IV insulin and we give glucose so they don't get hypoglycemic. That helps with them. And then the ultimate thing at the end is something called lipid emulsion therapy, which is basically because most of these things will go into a lipid barrier. You can kind of trap it inside the bloodstream with the lipid emulsion therapy. Probably about once a year I do this here, usually in adults that are, I've yet to do it in a kid, but usually adults that have overdosed either in calcium channel blocker or beta blocker. Okay. Opioids. You guys have all seen this 1,000,001 times. More in the adults, some in your teenagers, right? Heroin seems to be the wonderful thing to do. And I love these reports that say people turn to heroin because we're mean, right? ERs didn't give enough pain medicine, so they were forced to go out into the street and shoot up with heroin. Oh, okay, that's kind of nice. I'm glad they did that. Is that kind of like, so if somebody didn't want to date me, I was forced to go out and beat somebody up because of it? I mean, wow, it's all their fault. Anyway, so what do you see with these? They typically have the pinpoint pupils, right? Small little pupils, sluggish. Their respiratory rate is way down, right? Again, think about kids when they get sick. Their autonomic nervous system should be going up. They should be tachycardic and tachypnic. If you get a kid that comes in that is breathing 8, 10, 12 times a minute, has small pupils, is just kind of out of it, all you need to do is find a little magic Narcan, and that'll help them, okay? And a lot of people, a lot of young kids are getting into pain medications by accident. A lot of teenage kids are raiding their parents' or grandparents' cupboard to try to get high. I once told, so I've got a senior in college and a senior in high school, and this was about 4 or 5 years ago. I was talking about some kid that I took care of from high school that got a hold of a bunch of Percocets, and my oldest at the time goes, "Oh, Dad, I can score you anything you want. You give me 20 minutes, I can score you that." And I was like, Jesus, okay. That's pretty interesting. I think you could get it faster than our pharmacy could get it for people. So, I mean, good for you, man. again, they're going to be bradycardic, but the big thing is their respiratory rate's going to be pretty low. So what do you want to do? You want to give Narcan. Now for kids, most of them are not habitual users, so you can go ahead and use a higher dose of Narcan, right? So if they're roughly adult size, you can go ahead and go up to 2 milligrams of Narcan. For most people, I will give a low dose, 0.2, 0.4 of Narcan. Why? Because I love my nurses, and I don't want them kicking me in the shins or other nether areas. Because if you take somebody who's habitually on narcotics and you completely block the mu receptors, which is what opiates work on, then they go into immediate withdrawals. And then they're miserable. And then they make your nurse's life miserable. And then your nurse makes your life miserable. And then everybody's just miserable, right? They start puking. They start having that piloerection. They start having horrible cramps. And they're just like, I'm in pain, I'm in pain. And now you screwed yourself because you can't give them any pain medicines because you've already blocked it, okay? So if they are teenagers, they've been using it a lot and everything else, a little bit of Narcan to wake them up, that's fine. Let them metabolize it. Don't worry about it. Almost no one will die on you if you are watching them and checking their oxygen and respiration if you give them small little doses of it. If there's a little tiny baby that hasn't been on it that you think maybe got a hold of, grandma's Oxycontin or grandpa's Oxycontin or something else along that line, 10 milligrams, pretty high dose for a kid, by all means. 0.1 mgs, go ahead and give them a milligram. All you're doing is blocking the effect. The kid's not going to go into withdrawals unless the kid's been taking it forever, all right? We do have, and you guys have probably taken care of some of our heroin-addicted babies when they're born, which is just a miserable existence for those kids. And the weaning process, are you guys still doing like 6-week weaning processes on some of these kids? Okay, yeah, and these kids, they literally go into withdrawals, and to me, there's almost nothing worse in the world to see than these poor little kids going into withdrawals, and they're shaking, and they're I mean, it's god-awful. There's a special place in hell for their parents. But, those are the only other crew that you have to worry about withdrawals on, okay? Fluid bolus, again, just because we do fluid boluses. Beta blockers look exactly like calcium channel blockers. For all intents and purposes, you really don't need to tell the difference between the two. The one thing, if you ever, for nursing boards or for PA boards and things, hypoglycemia is what we typically look for beta blockers, okay? We will sometimes give glucagon to these folks to reverse some of the effects of it, but otherwise they'll get the same sort of thing. If you accidentally say this is a calcium channel blocker and give them some calcium, you're not going to hurt them. But the classic one is that they'll get hypoglycemia where you don't get hypoglycemia in calcium channel blockers. Now, that being said, my last 2 calcium channel blocker overdoses were both hypoglycemic, and my last 2 beta blocker overdoses weren't. So they obviously didn't read the book. Okay. So they're bradycardic. They look the same sort of thing. And how do we treat them? Basically the same way we do calcium channel blockers, right? A little bit of fluids, insulin, glucose, maybe some glucagon, lipid emulsion therapy, epi-drips if they're really crashing. Yes?
Does atropine work for beta blocker overdose?
Nope. You're not going to hurt them, but you won't get much of a response. Mm-hmm. It doesn't do much for you. But again, so we're going to get back to our ACLS logarithm, right? Atropine is falling less and less and less out of favor. It used to be a milligram, now it's a half a milligram that we're giving and everything else. You're not going to hurt somebody by giving atropine. You just really aren't going to cause any huge problems. We have this big debate all the time, and forgive me for going back into ACLS, but we look at 3rd-degree heart blocks all the time. There's a big debate, should I give atropine because it's actually a complete heart block. There's really no association at all between the atria and the ventricle. And yeah, go ahead and give it. You're not going to have any problems with it. Is it going to work? No. But you're not going to hurt anybody by doing it. So, if in doubt and you're standing around going, I don't know what else to do, and I'm going to start transcutaneous or transvenously pacing this patient, fine, give them atropine. Let's see how you do there. Cocaine and amphetamines. I've yet to see a little kid get into, they'll get into everything, but somehow the parents seem to keep their meth pretty well to themselves. And their cocaine, not too many kids showing up with a little white on their nose. Lots and lots and lots of teenagers, though. And I'm going to throw in here on the amphetamines all of the stimulants for the ADHD drugs. And these kids are grinding them up, snorting them, doing all sorts of, packing, everything else along that line. So what do these kids come in looking like? Well, they look like John Belushi from Saturday Night Live. And I know I'm dating myself, but they're wild and crazy. These kids are amped up. They're tachycardic. They're sweaty. They're agitated. They're out of their flipping minds. They're just, going berserk and everything else. So these kids have big old dilated pupils. You can imagine, anyone who's amped up, that's what they look like, okay? So what do we do with these kids? Again, usually teenagers, they're coming in, they're belligerent, they're fighting, somehow the cops have picked them up, things along that line. If you see that and go, I don't want to be in the same room with this little terror, right, then you know it's probably going to be some sort of sympathomimetic, cocaine, amphetamines, and all of the little derivatives in there. If you get an EKG, they're going to be in some sort of wild sinus tachycardia, fairly significant. They will usually be hypertensive, okay, and they'll be sweaty, 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 sweaty. Okay, why do I keep stressing sweaty? Because there's another one that I don't have on my slides that looks a lot like it, and I'm seeing a lot more people abuse it, and that is Benadryl. Okay, your anticholinergics. Right? Jimson weed, loco weed, things along that line, they will do the same sort of thing. And that blocks acetylcholine, so it blocks the vagus nerve, and these kids will be tachycardic, crazy, so dry as a bone, mad as a hatter, if you guys remember all that other stuff. And they look the same thing, except the difference for them, they're dry. They don't sweat. So if you see me in the emergency department with someone that comes in that's tachycardic, crazy, and all that other stuff, and I walk up and I put my hand in their armpit, it's not because I'm a creepy old man. It's because I'm looking, well, I might still be, but I'm looking to see, are they sweaty in the armpit? Because if they're not sweaty in the armpit, then I'm thinking it's much more likely to be a overdose of Benadryl, which is the most common one, or one of the other ones that are going to be something like that. It's an anticholinergic. If they're sweaty, then it's going to be more likely this. Okay? Now, with the anticholinergics, we can use physostigmine, which we typically don't, but that'll completely reverse them and they'll be fine. I used to do this all the time in the military bases when I was working, paying off my scholarship, because a lot of these guys, you know, they're super hard chargers and they'd have a cold and they're going to go out into the field. And unfortunately, some of our military grunts are not the brightest guys in the entire world, thinking, well, if 50 milligrams of Benadryl is good, then obviously 500 milligrams must be better. And so these guys would take it all at night to try to sleep, to get ready. Buddies would try to wake them up the next morning. They're loopy as all hell. And so they'd come in and you look at them and you're like, oh, yeah, this is Benadryl overdose. We give them some physostigmine. They wake up and they're like, yes, sir, I'm ready to go, sir. Oh, killing machine. We're like, okay, physostigmine lasts about 15 minutes and then they go right back down. But then we go, got our diagnosis and done. So what do we do with these amphetamine overdoses and everything else? Benzos. That's it. Chill them out. Okay? 15-year-old comes in going wild and crazy, got into amphetamines, got into, you know, a whole box of Ritalin, whatever else. We give benzos. Okay, Valium, Ativan, I don't care which one you want to give. How much do you give? You give them enough until their heart rate and their blood pressure comes down and you have them under control. Okay, my pediatric colleagues probably aren't taking care of too many peds with withdrawal symptoms from alcohol. I'm hoping not. You guys don't use the CEWA protocol. Those of you guys that are everywhere else, same sort of thing that we see with alcoholics that are withdrawing, right? They have this massive surge in their sympathetic nervous system, and we're trying to blunt that with benzos. And we're just treating it to that area. And eventually they'll metabolize it. Okay, cocaine, fluid boluses. Oh, watch for hyperthermia. You know, if they have too much of it, their body temperature can get too high. So just be careful with that one. Okay. So, yes?
You mentioned earlier that time you mentioned alpha blocker.
Yep.
How about alpha?
The problem is that you can get unopposed beta stimulus with the heart, and that's why they try not to do it. There is a medication, phentolamine, that you can sometimes give for cocaine overdoses if you have just wicked hypertension. I would argue if you are reaching for something like phentolamine that you probably just have not given enough benzos. Because these people are not going to sleep. These are not like I give 2 Ativan to grandma and she's snockered and breathing it 6 times a minute. These guys are already wired. I gave one guy who ingested, he was like carrying the cocaine in the little baggies in his abdomen that broke in an airport when I was up in Washington. I gave him 60 milligrams of Ativan just to get his heart rate and everything down under control. So yeah, you can give tons and tons. And if you've taken care of alcoholics, we go 10, 15, 20 milligrams of Ativan at a time when they're going into DTs and everything else like that. So yeah, just keep pushing that one, and that will bring their blood pressure down. But there are a few other little tricks that we can give. Technically, you're not supposed to give these folks beta blockers, again, because then you have unopposed alpha blockade. That's kind of been debunked as a myth. But again, you really never even have to go to those. You just need to keep giving more and more and more benzos. Benzos will eventually fix this. We have more benzos than they have cocaine in their system. So summary, if a kid comes in with toxic stuff or an ingestion, try to figure out what it is. Always worry about co-ingestants. Our tox center is wonderful. It's at Detroit Children's Hospital. They are fabulous. Even if you know exactly how to treat them, so some kid got into their grandparents' Oxycontin, and you're like, great, I know how to do this. This is Narcan, and I can ride this whole thing. Give them a call. That's how they get their funding, and they'll help follow you through and things along that line. If you're not really sure, they'll tell you how long it takes for these medications to metabolize. Some of them, I didn't mention this earlier, but watch for the extended release, especially like the calcium channel blockers and the beta blockers, because quite often what you'll get is, I'm not sure if little Johnny or Sally took it, right? I saw it, maybe there was a pill, I'm kind of half blind anyway, maybe there wasn't a pill, maybe it was a cockroach, I don't know, something's gone. If they're extended release, you're going to have to watch these kids sometimes up for 24 hours, okay, because it takes a while for these things to get kicked in. Always consider the co-ingestions. So if they get into things like Norcos or all that other stuff, remember Tylenol is on the other side, and my Tylenol lecture is a complete lecture unto itself. Fluid boluses, and then EKGs, and just have a low threshold for watching these kids. Don't err on going, yeah, I don't think the kid did it. Just watch them, okay? Most of these will manifest some sort of physiological change within 4 to 6 hours. It's okay. Just camp them in the ER, give them a popsicle, and go from there, right? Any questions? Okay. And I know Kim wanted to do a Q&A about some other things.